So, hi everyone. Welcome to today's quarantine clinic. Today, we will be discussing how to approach a case of hemiparesis and stroke. So, yesterday we took basics of neurological examination, and today we will be discussing just hemiparesis. And from tomorrow, we will be taking each clinical case one by one and going into an in-depth overview of each one. So for today, let's discuss how to approach a case of hemiparesis. Now, hemiparesis means weakness on one side of the body, so half of your body. So in a case of hemiparesis, you will have weakness of only the right side or only the left side. So you will have weakness of just right upper limb and lower limb or just left upper limb and lower limb. And you may also have weakness of the face. So this is the classical presentation of hemiparesis, and this can present in multiple ways, and it can present because of multiple reasons. So that is what today's clinic is going to be about. So before we understand what are the ways in which hemiparesis could present, we first need to understand why is hemiparesis happening at all. And the reason that this is happening is because the motor tract in the body is involved. And the main motor tract in our body is known as the pyramidal tract. It is also known as the cortico-spinal tract. Okay, so this is the tract that is involved, which results in weakness of one side. So before we move any further, we need to know a little bit more about the pyramidal tract. So let me tell you about the neuroanatomy of the pyramidal tract. So if you want to move your right hand, the command to move the right hand comes from the left half of the brain. So the left hemisphere controls your right side of the body. And the way this controls it is that your left hemisphere, your left brain, has an area called motor cortex. So there's a right motor cortex and there's a left motor cortex. So if you want to move your right hand, your left motor cortex will send a signal, and that signal will leave the motor cortex through the tract known as pyramidal tract. And this tract will come down the neuroanatomy, it will reach the brainstem, it will cross over to the other side and then go further down in the spinal cord and then leave the spinal cord at the level that it is supposed to control. Okay, so instead of your right hand, if you want to move your right leg, then the corticospinal tract will come down till the brainstem, cross over and come all the way down to your lumbosacral plexus, then exit and then control your limb. Okay. Now, this is the overall anatomy of the pyramidal tract, and there is a pyramidal tract on both sides. So if you wanted to move your left side, the tract will come from the right side of the brain and then cross over and come like this. So what this means is that at the level of the brain stem, there is an area where the pyramidal tracts cross. It's also known as decussation. And this happens at the region of the medulla. Okay, so at the lower medulla is where the pyramidal tracts cross over to the other side. Now, if we are considering that there is weakness on one side of the body and weakness of the face, then the pyramidal tracts have to be involved at some level above the highest level of weakness. Okay. So, for example, if supposing there is only weakness of the legs, then the pyramidal tracts may be involved at any level above the lumbosacral. But if you say that there is pyramidal weakness of the hands also, then the level of the lesion comes up to the cervical cord or higher. And if there is weakness of the face, then the level of the lesion comes to the brainstem or higher. So in a case of hemiparesis, when we say that both hands and legs are involved, the level of the lesion has to be either in the cervical cord or higher up. Now, that is what we'll be discussing next, that what are the levels at which there could be a lesion. So now let's look at a cross section of the brain. Now, this is the motor cortex. And the motor cortex is actually in the posterior part of the frontal lobe. So motor cortex is actually part of the frontal lobe. Now, if you remember, we have discussed that frontal lobe is in the anterior part of the brain. It is the anterior lobe, and the motor cortex sort of lies right between the frontal lobe and the parietal lobe. So this is the parietal lobe. Now, this is where your motor cortex is where your pyramidal tracts start. And it will come all the way down to the brainstem. Now, in the brainstem, there are 3 levels. And if you remember from yesterday's discussion, these are midbrain, pons, and medulla. Now, at the level of the medulla, the pyramidal tract will decussate to the opposite side and then come down and then exit. So, what are the levels at which there could be a lesion? There could be a cortical lesion. So by cortical lesion, I mean that there could be a lesion in the motor cortex itself. There could be a lesion somewhere between the motor cortex and the medulla. Now, what are these areas? Now, one of them is an area right after the tract leaves the motor cortex, and that is known as corona radiata. And if it comes down a little bit more, there is an area known as internal capsule. Then there could be a lesion in the midbrain, pons, or the medulla. That is the 3 parts of the brainstem. And lastly, there could be a lesion in the high cervical cord. Okay. So these are all the areas in which there could be a lesion that will lead to hemiparesis. Because anything lower than the cervical cord will spare the arms, that is, it will spare the upper limb, and it will only involve the trunk and the lower limb. So that would not make it a hemiparesis. For hemiparesis, you need involvement of both the arms and the legs. That is why the level of the lesion will stop at the cervical cord. Okay, so a dorsal lesion or a lumbosacral lesion will not cause hemiparesis. So these are the different areas in which the pyramidal tract can be involved and can cause hemiparesis. And if you remember from yesterday's discussion, the whole purpose of the neurological examination is to find out 3 things about the lesion: the where is the lesion, the what is the lesion, and the why is the lesion. So all that we are discussing right now is to help us come to the conclusion of where is the lesion. Okay. So before you know where is the lesion, you have to know what are the possible sites of the lesion. So these are all the possible areas where the damage could be. Now, how do you go about it? So if there is damage in any one of these areas, you know your pyramidal tract will be involved. But in order to know which one of these areas is involved, you need to check what else is involved apart from the pyramidal tract. One. And two, what is the quality of involvement of the pyramidal tract? Now, why is this important? So let's take it from above to below. Now, suppose there is a lesion in the motor cortex. Okay. Now, the characteristic of the motor cortex is that the pyramidal tract leaves from a wide area, because there are different areas that are responsible for different parts of the body. So suppose there is a fiber that controls the hand, there's a fiber that controls the leg, a fiber that controls the face, fiber that controls the trunk. So when it's leaving from the motor cortex, the fibers are all spread out. So if there is one lesion here, say it is a lesion of 1 centimeter in diameter, that will most likely cause a small lesion, because there will only be a few fibers that are involved. But as the fibers come down, they converge and they form a smaller, thicker, more dense structure until it comes down to a point where all the fibers are bound tightly together. Okay. So a same size lesion of say 1 centimeter in the motor cortex will cause less harm than the same size lesion in the say corona radiata. And that same size lesion will cause less harm, even more harm in the internal capsule. Okay. Because the fibers are getting more and more closer together, a same size lesion will affect more and more of the fibers, and the more fibers get involved, the more the damage. Okay. So that is one way to differentiate between these three: your cortex, your corona radiata, and your internal capsule. The internal capsule will lead to what is known as a dense infarct or a dense hemiplegia, because a small infarct will lead to a large stroke, a large defect. Then what will happen? After this, the fibers have now entered into the brainstem. Now, in the brainstem, it will first enter into the midbrain. And so this is the midbrain. Now, what are the other things that are there in the midbrain? So the midbrain has mainly two other things that you need to remember right now. One is it has the nuclei of third cranial nerve. So your third cranial nerve is your oculomotor nerve, and that controls eye movement. So if there is a midbrain stroke, you will have involvement of your pyramidal tract. So that will cause your weakness. But if there is the same size lesion here, then there is more chances that your third nerve nucleus will also be involved. So you will have eye movement problems. Okay. And another thing that your midbrain has is something called as reticular activating system. And if this is involved, you will have a problem in your consciousness. So if there is a large midbrain stroke, it is more likely that a person will be in a comatose state. Now, Reticular activating system is not just in the midbrain, it actually extends down all the way. So any brainstem stroke can lead to a comatose state or a depressed consciousness state. Okay. Now coming a little below to pons. So now your pyramidal tract is in the pons, and if there is a lesion in the pons, what would happen is your pyramidal tract will be involved, and there will be involvement of some other nuclei in the pons, and those are your sixth and seventh cranial nerves. So sixth and seventh is your abducens, which also controls eye movement, and facial. And facial nerve is one of the most important nerves to look for in a case of hemiparesis. And I'll get to why that is. But for now, just remember that if there is a pontine or a pontomedullary stroke, then your facial nerve is more likely to get involved. Then finally, at the bottom is your medulla. And your medulla has all your lower cranial nerves. So cranial nerves 8, 9, 10, 11, and 12. So these are your lower cranial nerves. And if there is hemiparesis, so your pyramidal tract involvement, plus any of your lower cranial nerve involvement, then it is more likely to be a medullary stroke. Fine. So this is how you come to a diagnosis, and of course, coming still further down, you reach your high cervical cord. So in your high cervical cord, if there is a stroke, the important thing to know is that the pyramidal tract has now already crossed. So the pyramidal tract crosses over in the lower medulla. So if there is a high cervical cord lesion, first of all, it will be an ipsilateral weakness. So if there is a left-sided cervical cord lesion, there will be a left-sided hemiparesis, which is not the case anywhere above this level. Above this level, for a left-sided hemiparesis, there has to be a right-sided lesion. But below the medulla, it will be an ipsilateral lesion. So that is one. And two, there will be no involvement of any of the cranial nerves. So if there is a hemiparesis with zero involvement of any of the cranial nerves, then you need to think of a high cervical cord lesion. And there are other features of a cervical cord lesion. So if there is a large lesion, there could be a respiratory weakness, okay, because of diaphragmatic weakness. All right, now that is about the where is the lesion. I just want to tell you one line about facial nerve and why it is important in a case of stroke. So in all your other cranial nerves, if this is the brain, and then here I'm drawing the brainstem and the cervical cord. In all your other cranial nerves, if there is a cranial nerve on both sides, okay, so this is cranial nerve 3, 4, 5, 6, 7, 8, 9, 10, so on. Only in your facial nerve, and that also in the lower part of the face. So your facial nerve supplies your entire face, the sensations in your, your motor involvement in your entire face. The fibers of the facial nerve that supplies the lower half of the face. These fibers are only supplied by the opposite half of the hemisphere. Okay. Whereas the fibers of the upper part of the face have a bilateral supply. So the upper half of the face gets supplied from both sides, whereas the lower half of the face get a supply only from the opposite side. And why is this important? Supposing there is a lesion on one side, the upper half of the face will still get a supply from the non-involved side of the brain, but the lower half of the face will not get any supply, and so there will be weakness. Okay, is that clear? So your lower half of the face is more likely to get involved if there is a hemiparesis, because that is the only one that is purely dependent on the contralateral side. Now, in keeping with the facial nerve, there is one specific lesion that would involve the facial weakness on one side and the body weakness on the other side. Now, what does this mean? Supposing there is a stroke on the left motor cortex. Okay, so this is the left motor cortex. So that is your left half of the brain. Suppose there is a lesion. Now, I already told you how the pyramidal tract will come here, cross over, and then supply the right half of the body. So that means that the weakness will be in the right hand and the right leg. But in the brainstem, so this is the brainstem area. So in the brainstem, the nerve fiber to the facial nerve will come from the brainstem at the pons level. Correct? Now the lesion is here. Therefore, the weakness will be on the right side. So if there's a lesion on the left motor cortex, there will be a weakness of the right facial nerve. Right lower face will be weak. And this is how it is usually the case. So the facial weakness and the body weakness will be both on the same side. Now, there is a very specific condition in which your facial weakness is on the opposite side. So there's a right-sided hand and leg weakness. There will be facial weakness on the opposite side. So there is a left facial weakness with a right hemiparesis. And this is known as crossed hemiplegia. And this happens if the lesion is not in the cortex, but rather it is in the midbrain. Sorry, it is in the pons. So the lesion is in the pons, exactly at the level where your facial nerve nucleus is there. So if there is a facial nerve nucleus involvement along with the pyramidal tract involvement, then the weakness will be on the same side as the nucleus, but the pyramidal tract will still have to cross over below. So that is why the pyramidal tract will cross over to the other side, but the facial nerve will be involved on the same side. Okay, I'm going to draw this again from another perspective. This is the brain and this is the midbrain and pons. And this is the pyramidal tract that is coming from here and then crossing over in the medulla and coming down. If there is a lesion here, then the weakness will be on this side. But supposing there is a lesion at the level of the pons, then the hemiparesis will still be on the opposite side, but the facial nerve involvement will be on the same side of the lesion. Okay, so ipsilateral facial and contralateral hemiparesis. And this is called as crossed hemiplegia. Okay, so that completes the approach to where is the lesion. Okay, now one line on the size of the lesion. I have already told you how a small stroke can cause dense hemiplegia if it involves the internal capsule, whereas a small stroke will cause a mild hemiplegia if there is involvement of the cortex. What if there is a large stroke of the cortex? Okay, so depending on the size of the stroke, suppose if it is a large stroke, so this could be either an infarct or a hemorrhage. I'll get to what is infarct and hemorrhage, but if the size of the stroke is large, there will be a pressure effect. So this is something that I just want you to remember, that if the size of the stroke is large, there will be a pressure effect on the surrounding structures. We'll circle back to this later after we have finished discussing the types of hemorrhage, types of strokes. Now coming to the next part of the discussion, we've finished where is the lesion. Now we will talk about what is the lesion. And when we say there is a stroke, what we essentially mean is that for some part of the brain, there is no blood circulation. So that means that your brain, a certain part of the brain is now undergoing ischemia. So there's no blood circulation. And the reason for this could be that in your blood vessel, there is either a blockage, so that means that there is a clot which is preventing the blood to flow onwards, or there is a leak. So there is a rupture of your blood vessel causing blood to spill out, which will lead to one, there will be no blood flow further down because all the blood has come out. And second, there will be a pressure effect because of the blood collection. Okay. So these two types are known as ischemic infarct and hemorrhagic infarct. Okay. So both of them will cause infarction. Infarction means necrosis due to low blood supply. Okay. So both of those will cause infarction, but if there is only ischemia, no hemorrhage, then it is likely to be because of a clot. And if there is hemorrhage, then hemorrhage will lead to both ischemia and pressure effect. And the two types of ischemic lesions are thrombotic and cardioembolic. So when we say thrombotic, we mean that if there is a blood vessel, then there is a plaque formation causing a thrombus, and that prevents your blood from flowing onwards. And when we say cardioembolic, what we mean is that because from your heart, there may be a small plaque that is released into the arch of aorta, which may go all the way up to the brain, causing blockage. Okay. So that brings us to blood supply of the brain. And it is very important to have an overall idea of how the brain gets blood supply. So there is basically two forms of, sorry, Bhavesh has just asked, it will be an ipsilateral LMN facial nerve palsy. Yes. Yeah, you're talking about crossed hemiplegia. Yes. So if there is a lesion at the nucleus level, then it will be a LMN lesion. I'll discuss this on Monday when I discuss UMN versus LMN. So what is the difference between the two? But in the case of the facial nerve, as we discussed, if there is a lesion in the cortex, only the lower half of the face is involved. But if there is a lesion at the nucleus level, then there will be a lesion of the entire face. Okay. Now coming to blood supply of the brain, there is two sources of blood supply. One is called the anterior circulation and second is called the posterior circulation. So I'll take it right from the heart itself and then go upwards. So suppose this is the heart and this is the arch of aorta. Okay, so this is right atrium, right ventricle, left atrium, left ventricle. Now, you on the right side you have your brachiocephalic artery, and from your brachiocephalic artery you have your common carotid artery and your subclavian artery. This is on the right side, and on the left side, directly from the arch of aorta, you have the left common carotid artery and the left subclavian artery. Okay, so this is the first part. After this, from your common carotid artery, there will be two branches, your external carotid artery and your internal carotid artery. The external carotid artery will supply the outside part of your face, your neck, and internal carotid artery will go into the brain. And inside the brain, it will split into two, the anterior cerebral artery and the middle cerebral artery. And this forms part of the anterior circulation. And posteriorly, from your subclavian artery, there arises from both sides, there arises the vertebral arteries. And in the back of the brain, it sort of ascends next to the spinal cord. And at the back of the brain, these two come together to form the basilar artery. And the basilar artery then splits into two branches known as the posterior cerebral arteries. And this forms part of the posterior circulation. Okay. So the anterior circulation and the posterior circulation. And at the base of the brain, the anterior and the posterior circulation meet and they form like a circle of anastomosis known as circle of Willis. So the arteries from both right and left and anterior and posterior. So the circle of Willis is essentially both the internal carotid arteries with ACA and MCA. So this is ACA on both sides, MCA on both sides. And here you have the basilar, and then you have both your posterior posterior cerebral arteries on both sides, and you have communicating arteries between your two anterior cerebral arteries, and there's a posterior communicating artery between the MCA and the PCA. So this is known as the circle of Willis. And the role of circle of Willis is to make sure that you can get blood supply from, if there is a supply problem in your right side, then your left can supply it. If there's a supply on your left side, then your right can supply it. Or if there's a supply in the anterior or posterior, the supply problem, then your whichever circulatory system is still intact, that can compensate for any loss, provided that the loss is slowly. Okay, so if there is a slow growing ischemia, then you can have collateral circulation coming in from the other side. So that is the concept of circle of Willis. Now, in the brain, how is the distribution divided? So your anterior circulation will supply the anterior part of the brain. This is the anterior cerebral artery. The middle cerebral artery supplies almost the entirety of the middle part of the brain, and the posterior cerebral artery supplies your occipital lobe and your brainstem. Okay. So this is how it is divided, which is anterior cerebral artery, middle cerebral artery, and posterior cerebral artery. And your brainstem is your basilar. Okay, now there are a couple of questions. Why only facial nerve is involved in the cortical lesion? Why not other nerves? So, okay, let's come back to that for a second. Let's take all your other nerves. Let's take your like oculomotor, for example. In all your other nerves, you have the command coming in. So if you take your right oculomotor, you have the command coming in from your left half of the brain, but there is also that there is a sort of supply coming in from the other side as well. Okay, and similarly to all the other nerves, there are only a couple of exceptions. So in your facial nerve nucleus, so in order to understand this, you need to sort of zoom into this area. So in the nucleus of the brainstem, so if you take this a little bit more closely and you say that this is the nucleus, so in the nucleus of the facial nerve, there are two halves. So there is an upper half and there's a lower half. Now the upper half supplies the upper half of the face and the lower half supplies the lower half of the face. Now the upper half gets input from both sides, whereas the lower half gets input only from the other side. So that is why if there is a lesion in the nucleus itself, then it doesn't matter where the input is coming from and all, because finally the nucleus itself is gone. But suppose there is a lesion only above the nucleus. So there is a lesion either on this side or on this side. Either way, then the upper half of the facial nerve nucleus is getting an alternate input from the opposite side, but the lower half of the facial nerve nucleus is getting an input only from the opposite side. So if there is a lesion in the opposite side, then the lower half of the face has no input. That is why the lower half of the facial nerve nucleus gets paralyzed and the upper half of the facial nerve nucleus is spared. Okay. So this concept of the nucleus getting differential input is there in a couple of other nuclei also. So even in your 11th nerve nucleus, there is a difference in your upper half of the nucleus and the lower half of the nucleus. But for your basic approach to hemiparesis, this is the only important part that you have to remember, that your nucleus is getting differential involvement, differential input. All right, so now we have covered where is the lesion, we have covered what is the lesion. So what is that? It is an infarction, and that infarction can be because of either ischemia or hemorrhage. And ischemia can be due to thrombosis or a cardioembolism. And this is the blood supply of the brain. So these are all the areas that can get either a clot formation or bleeding, so hemorrhage. Okay. Now coming to when I say what is the lesion, coming to a sort of zoomed in approach or at the infarction itself. Now let's say that this is the blood vessel. Okay, and it is supplying a very specific territory. It is supplying the internal capsule. Okay, so this is the part of the brain where the pyramidal tract has sort of condensed into a very tight spot. So if there is a small lesion also here, it will lead to a dense stroke. Now suppose this is the blood vessel that is supplying this internal capsule. So it goes all the way here. Okay. Now suppose there is a clot here. Now, if there is a clot here, your blood will not be able to reach to the internal capsule, and that means that there is an infarction. So when I say infarction, what do I mean? So if this is the cortical area, this is the area of that this blood vessel was supplying. Initially, there will be signs of ischemia and necrosis at the center. Okay. And as the ischemia grows, this necrosis keeps increasing. And eventually, there will come a time when the central portion is beyond repair, but the size of the necrosis will keep growing, but the periphery of this lesion is still salvageable. And this periphery is known as the penumbra. And the central region is called the core of the infarct. So this part is already dead. There is nothing you can do to save the central part. But if you act quickly, and by acting quickly, what do I mean? That you somehow remove this clot and you somehow remove this blockage so that you can re-establish blood supply. So if there is blood supply, then you will finally end up with a lesion that is only so much. Whereas if you don't re-establish blood supply quickly, you will end up with a lesion that is much bigger. Okay. And you have very little time from here to here. Okay. So if you are giving an injection in order to re-establish the blood supply, you have around 3 hours, which is known as the golden window, in order to save this peripheral region. And that is why in stroke, we say that time is brain, because every second you waste, another layer of neurons are getting added to the central core area. That means that they are lost forever. And every neuron is important because that makes our recovery easy. So you have more chances of recovery with rehabilitation and all if you save more neurons. So this is the concept of how the infarct grows. And this is important when we talk about treatment. Now let's talk about, we finished where is the lesion and we finished what is the lesion. Now let's talk about why is the lesion. So that is, why is there a stroke? And the why depends entirely on the type. So supposing we are talking about an ischemic stroke, and specifically we are talking about a thrombotic stroke. So in thrombosis, what happens is, in a blood vessel, you have a slowly growing plaque which keeps increasing in size until one day the blood flow is stopped. So anything that can increase plaque formation can be a reason for stroke. And when I say plaque formation, what I mean is atherosclerosis. So all the risk factors for atherosclerosis are risk factors for stroke or causative factors for stroke. So these are, if you have increased lipids, diabetes, blood pressure, if there is a sedentary lifestyle. Now these are risk factors, of course. Smoking, tobacco. Okay. So these are all risk factors for atherosclerosis. So the more risk factors you have, so if you have diabetes and blood pressure and you smoke and you have a sedentary lifestyle, then your chances of getting atherosclerosis, plaque formation, and thrombotic stroke are more. And the second reason for increased plaque formation is inflammation. So anything that causes increased inflammation can lead to increase plaque formation. So for example, vasculitis. So anything that causes inflammation inside the blood vessels can lead to more thrombus formation. Now suppose the ischemia is an embolic stroke. So when I say embolic, that means that the clot hasn't formed there, the clot has formed somewhere else and then traveled to that spot. Now where can it come from? It can come either from the heart, so that is cardioembolic, or it can come from another blood vessel, a bigger blood vessel. So that is artery to artery embolic. So if it has come from another artery, then it is likely that that artery had the plaque formation and atherosclerosis. So the same risk factors will apply there. But if there is a cardioembolic, there are specific conditions in which your heart will have uh, plaques, which can then break off and then travel all the way to the brain. So one of them is rheumatic heart disease. So if suppose there is mitral stenosis or mitral regurgitation, there is stasis of blood. There is blood stasis in the left atrium, and anywhere where there is stasis, there is increased thrombus formation. So if there is a thrombus formation in the atria, then that can break off, enter the aorta and go all the way up. Another reason that there could be stasis is atrial fibrillation or infective endocarditis. So in infective endocarditis, there is vegetation, and pieces of those vegetations can break off and go all the way and form clots. Okay. And finally, if it is a hemorrhagic stroke, then the most common cause of hemorrhage is hypertension. And in hypertension, what happens is that there is increased pressure in the blood vessel. So in a blood vessel, there is continuous pressure being exerted by the blood onto the vessel wall. Now, if this pressure increases very much, then eventually there will be a rupture and there will be a clot formation, or rather a hematoma formation. Okay. So anything that increases the blood pressure inside the blood vessels can increase your chances of getting a hemorrhagic infarct. And so all your risk factors for hypertension become risk factors for hemorrhagic stroke. So if you have a renal disease, or if you have say if you have aortoarthritis, any of those reasons can lead to hypertension. If you have primary hypertension, familial hypertension, so all of them are risk factors for hemorrhagic stroke. And another reason for hemorrhage is anticoagulation. So suppose you are on anticoagulation, suppose you are on heparin or warfarin for any reason, then that will increase your chances of bleeding. So even if there is a small leakage, there will be no local thrombus formation because you are taking anticoagulation. So that can lead to increased chances of bleeding. And in the brain, the areas that are most likely to bleed are your small blood vessels, because your large blood vessels have a thicker vessel wall. So this is called as intima, layer intima, and this is thicker in your large blood vessels. But in your thin blood vessels, the blood vessels that are at the center of your brain, they are more thinner, so they are more likely to bleed. So this is in your basal ganglia, that is in your putamen, thalamus, and also in the cerebellum. Fine. So that covers your where is the lesion, what is the lesion, and why is the lesion. Now finally coming to investigation and treatment. So basically management is investigation and treatment. So investigation, the first investigation of choice is a CT scan. And in a CT scan, you are primarily looking to diagnose a hemorrhage. And if there is no hemorrhage, then you are looking for an infarction. But an infarction will take some time. So an ischemic infarct will take time to show on the CT scan. So if there is no hemorrhage and if you can't see the infarction, then you go for an MRI brain. And this, especially with a diffusion scan, will tell you if there is an infarct or not. Once your evaluation is complete, this is only for where is the lesion. You'll also evaluate for what and why is the lesion. So you look for risk factors, you'll check for diabetes, hypertension, if there are any anticoagulations, in which case you'll do PT-INR, all those tests you'll do. And then treatment. Treatment depends on time. So at what time did the patient come to you? If it is a hemorrhage, the decision to be made is surgery needed or not? And the surgery is, you can either do a clot evacuation, so your hematoma evacuation, or you can do a hemicraniectomy for relieving the intracerebral pressure. So supposing there is a large bleed, then that bleed will compress on the brain. So if you do a hemicraniectomy, that pressure will be transmitted outside. So that can prevent herniation. And if it is an infarct, you check for time of the time of the infarct, how long has it been? And if it is within 3 hours, you can go for something called as thrombolysis. So thrombolysis basically means that you give a medication which will lyse the clot. So if there's a clot here, you want to lyse the clot so that your blood will start flowing. Okay, and the common drugs to use for this is recombinant tissue plasminogen activators, that is called RTPA, and one of the common ones we use is alteplase. Okay, and after this, there are certain medications that you use to continue in order to prevent further chances of stroke in ischemic stroke, that is antiplatelets. And you go for rehabilitation, which is physiotherapy, and treatment of risk factors. So if there is diabetes, if there's blood pressure, if the patient is smoking, then you advise them to stop smoking. So all those other factors also needs to be managed. Okay, so that completes approach to hemiparesis and stroke. If there are any questions, you can ask me on the chat. And tomorrow there will be no clinic, and the next clinic will be on Sunday. That will be a neuroscience topic. So we'll be discussing the neuroscience of art. So how does the brain conceive art, and what happens inside an artist's brain when he or she tries to create art? And on Monday we will take UMN versus LMN. All right. Thank you all for listening. I'll see you on Sunday evening at 7 o'clock.